we kickstart. But to first introduce myself, I am Reena Sangar. I'm the head of digital and connected health at Ipsos. Ipsos are a global market research and insight agency. We work with data. But more than just collecting data, it's about interpretation of data that's really important to us. And the role of digital health in particular is my remit, and it's something we're incredibly passionate about. It's an absolute pleasure to be hosting Reach Live. Reach is a non-for-profit organization which focuses on driving thought leadership in digital health. And we have the pleasure and the privilege of having a number of senior clinicians, advanced academics who are part of the Reach organization. And one of such is Dr. Setu Vora, who is with us today. And we've got such an interesting topic around health equity in tribal communities. And we're not going to leave things off the table. We're going to have some real conversation today. So I'm really glad you're joining us. But before I kickstart my questions, Dr. Vora, please introduce yourself, give some context to how long you've been practicing and
Thank you, Reena. And thank you for inviting me to join you and Fran and Amir at the Reach Live event. And hello and welcome to all the participants. My name is Setu. And I grew up in India, trained there, came to US for my further training, and I've been in Connecticut since '98. I'm a pulmonary critical care and sleep medicine by background, but my current role is to be the steward to a Native American tribe for all its healthcare affairs. I serve as the chief medical officer for the tribe that is called the Mashantucket Pequot Tribal Nation here in Connecticut.
Fantastic. Before we get into the details, and I'm particularly interested in how it came about, how your story, how you came to understand about tribal communities and eventually that work for them and with them. The question we always open with is, how's your lockdown experience been and how are you coping with this extraordinary year? So how have you been?
Surviving, like most of us. Some days are better than others. I'm really optimistic that we are coming closer to that proverbial tunnel. I think we still have a few more darker months to go through, but the vaccines are rolling out, so I'm feeling good. I received my second dose. I did have systemic malaise, the man flu for 24 hours, but I survived that too. So things are up and up. And, Reena, to your earlier question around why working with tribal nations. I came to US and trained in Connecticut and was exposed to the two federally recognized sovereign tribal nations here in Connecticut. As many of the viewers and audience may already know, what we call the United States is native lands that is referred to as Turtle Island. And to have two such communities of native indigenous people within the state was a rare chance to learn more about their culture and traditions. And in doing so, I realized how much of a similarity and resonance it had with my own upbringing culture when I was growing up in it. So there was a natural affinity as well. And when most of us who work in acute care in the ICU, we see the last damaging impact of health and disease disparities. And there was a natural desire to perhaps try to go a little bit upstream and perhaps have an opportunity to intervene, assist people in their quest to bend the disease state, and perhaps focus a little bit more on prevention, both primary as well as secondary and tertiary. So that's how when the tribe approached me with the inaugural opportunity, it fit well with my own personal mission as well.
That's interesting. So the tribe approached you. Was it not? Did it come from any kind of government initiative or any kind of top down, or was this a bottom up kind of a process for you to get involved?
So yes, the tribes are sovereign tribal nations. They have their own jurisdiction, laws, constitution, and governance. And the Mashantucket Pequot tribe that I had the privilege of serving has been very forward thinking and pioneering in the uh, realm of exercising sovereignty as well as establishing enterprises, both gaming and non-gaming. So with that kind of forward thinking organization, and the fact that they had established a healthcare enterprise, they sought out someone who was local and perhaps who can assist them with the clinical subject matter expertise as well, to really bring their health systems to the next level. So they reached out, and they were one of the leaders in actually creating a position such as this.
Interesting. Yeah. So let's get into this. The conversation we have is around health equity, you know, and when we talk about health equity, ultimately what we're saying is that there is an inequality, you know, we don't have equal stakes. And when we talk about inequality, we're saying that something which could be avoidable, something which is unfair and possibly systemic, quite often actually systemic in our structures and our processes, which end up giving us a difference between groups of people, right? That's ultimately where the health equity debate is. And what I'd really love to understand now is the specific health inequities that you're seeing with the tribal communities.
Certainly, where to begin? I think, you know, it's certainly, to me, most of the experts would say it starts off with just being recognized. Now, when you have a data point that says that almost 40% of U.S. population currently believe that Native American people do not even exist. So that's the starting point that we are facing in the Indian country, in the Native communities, indigenous sovereign tribal nations. People just do not believe that indigenous people in the U.S. exist. So how do we become visible, be counted in a accurate, transparent, private, trustworthy manner, so that the data reflects the true disease burden as well? So I think it really starts out with something really fundamental, like the simple fact that there is acknowledgement and recognition that yes, Native Americans do exist. Even the dialogue around minority health often includes indigenous population almost as an afterthought sometimes in global national discussions. So yeah, I think, you know, it certainly starts by having more of the Native indigenous leaders represent and speak up, both at forums such as this and other national, international forum. Let's face it, besides US, there are indigenous communities throughout the world that are also facing the same barriers and challenges, right? So the lessons learned by our indigenous colleagues in Australia or in sub-Saharan Africa can also be applied to the communities here in US and vice versa. So there's a lot of possibilities of synergy of action around indigenous communities, figuring out ways to deal with same structural systemic racism and other barriers to care that we know exist.
It's so powerful. I mean, I worked in health inequity and mental health in the UK, and particularly with the Black and minority ethnic populations. I'll be honest, that until I got to know you better and understood, you shone light on this group of people, I hadn't even considered the impact on tribal nations and indigenous folk. And you're right, there's not enough dialogue and enough kind of focus. And this is the problem about not being counted, right? So if you're not in the numbers, if you're not in the ethnicity states, if we're not understanding access to services by the different protected strands, we can't do much about it. So how is that? I mean, is the documentation there? Is the coding there to understand access rates and things? Do you feel that that's getting somewhere, or is that still a challenge?
the box is there, but oftentimes the healthcare provider organizations may not have the same um, rigor around accurately capturing that data.
Mm,
Similar to sexual orientation, gender identity, it is perceived as yet one other administrative burden to the folks on the front lines. Sometimes I get it. That's one other thing to ask, and oftentimes it is perceived to be a sensitive topic, and people would much rather take a look at you and say, you look like this, and check the box without necessarily asking what your preferred identity is. So we
mm.
see that significantly across native tribal nations as well.
Yes. And I think sometimes just the frontline staff don't know the importance of those boxes. They think, well, people are people. Why do we tick? And that's absolutely genuine from them. I did an observation work in a clinic once where I observed that type of behavior. And then when I said, why it's important, it was an enlightening moment for that frontline admin staff. Let's go into the other elements of disengagement with services. What other types of things do you see in terms of the feelings that tribal communities have towards health services, and how much trust do they have towards the health system and healthcare professionals? I've been really keen to understand that.
Sure. Similar to the acknowledgement of just simple existence of the native people, there is also a real need to acknowledge, not to necessarily feel overtly guilty individually ourselves, but at least to acknowledge the historical trauma that the indigenous people have suffered through generations, right? And Reena, I mean, let's face it, this pandemic is not new for Native communities. If we recall our history lessons, with the Columbian exchange and the contact with folks coming over from other places to the Turtle Island, that brought on novel diseases and pathogens, right? We know that. But we also know that it was not just the diseases, but the disparities in policies and oppressive way of implementing those combined together really magnified the decimation of Native people to the tune of almost 80% over hundreds of years in US. And when you combine that with forced dislocation from their ancestral lands, loss of language, forced assimilation, where you really lose your identity in a sense. And then more contemporary and recent ongoing instances where the institutions that are supposed to safeguard health and well-being often fail them. Everyone on this panel, of course, would know about the experimentations that might have gone on. Certainly, forced sterilizations in certain reservations. Not to belabor the point, but certainly such inequities and mistreatment still persists. So it's not just the historical trauma, but the ongoing contemporaneous insulting trauma that keeps the community somewhat disengaged. And there's a level of mistrust where there is a questioning as to, are they trying to experiment on me? Is this vaccine going to cause any long-term change in my DNA? And such concerns, which may be really part of a disinformation campaign by other folks, really resonate well when you have a substrate of mistrust due to valid historical trauma.
Oh yeah, we're gonna come back to this point and really talk about what we can do about it as well. So whilst we're listing out the challenges, we've all come to some of the strategies that we could put in place to try and overcome. But the lived experience and the reality is, I think, stark in terms of what you've shared. The other element is around service access. So where there's health inequity, we see a lower level of preventative outreach work. We see a lower level of primary care access and a higher level of acute service access. How does that play out in tribal communities?
Great question, Reena. Many of the listeners may not know this, but actually Native American population is growing as a demographic group in the US. As of the last count, there were about 5.6 million Americans who identified as Alaska Native or American Indian, AIAN. That almost comes to 1.7, almost approaching 2% of the US population. Certainly, Alaska has many native cultures and tribes. And as most of us know, with the geographic distance and climate hardships that they face, access to care is a real problem and challenge. And it's no wonder that the innovative spirit of the native people did allow them to adopt digital health, telemedicine way before mainland lower 48 did, right? So sometimes adversity does bring out, innovation as well as we know it. So I think, one other myth is that all Native Americans live on reservations. And we know that actually 60% of indigenous people in the US live in metropolitan area. But the remaining 40% are in rural areas where access to care is always a challenge, both in terms of in-person care, recruiting physicians, other providers to come and stay in that area is a challenge, especially given the healthcare financing that the Native communities face through a combination of public and private payer source, such as the Indian Health Service and perhaps Medicaid and Medicare in some cases. Many of the tribes are able to supplement that with a self-funded health plan. So it's the kind of a mixed bag of payer status, and recruiting high-level, high-quality clinical team is often a challenge. Plus, you add the digital divide to that, so where you have a remote area with poor access to broadband or 5G, and now you're really, in on-prem isolation plus a digital divide that doesn't let you do what you need to do to access care through digital doorway first. So yeah, I think there's some major barriers right there with those type of challenges.
I don't know if you're aware of this or not, do you have a sense of particular therapy areas or conditions which have a higher rate of low access, low prevention because of this factor? Is there a hierarchy at all in the therapy areas?
Yeah, I mean, it's true not just for our indigenous people, but perhaps true for all of us. Mental health disorders are heavily underdiagnosed, unrecognized by individuals themselves, and of course, care provider team. And but because of that, they are undertreated, right? So, and we know that comorbid mental health disorder, along with, say, for example, diabetes, COPD, congestive heart failure, God forbid, other autoimmune diseases or cancer, the outcome trajectory is so much different when there is comorbid mental health disorder that is undiagnosed, untreated. The adherence to therapy is lower. Follow-up to care is lower. Unmet social needs go unidentified. And that results in, significant delta in survival rates, clinical remissions. And we see that play out in the Native communities, where the incidence prevalence rates for diabetes are much higher than non-Hispanic whites in the US. We know that. And then resulting, need for preventable limb amputations or end-stage renal disease, those being the hard endpoints of something preventable outcome, had the diabetes been managed a little bit better. Those type of obvious disparities are really what drives all of us who are trying to help, reshape the dialogue around Indigenous health.
So there's quite a few things here. If I summarize, we've got low awareness just an education need around, you know, these somewhat hidden individuals, this whole hidden culture that just doesn't come in the frame and is often a, you know, an afterthought, you know, in terms of even the BAME language of Black and minority ethnic. It's kind of just clubbed in. So we've got a real low awareness. We're not coding appropriately, so therefore we don't know the real numbers. Recognition around numbers is an issue. There's trauma within the community, historic trauma that needs, I think, just recognition, firstly, and acceptance that happened. That's a real lived experience. And then what that means for distrust in the health service, distrust of medicine and recommendation. And all of that kind of also coming to very low access to key services. What are some of the things that we can do? You know, it is a big thing. It's not small. It's not going to happen overnight. And I'm sure this has been a challenge for you for many years. Let's talk about some of that. Let's talk about some of the things that we can do that will really start to make a difference.
Yeah, Reena, and as you pointed out, and my tribal leaders, tribal elders remind me that the problems that we are facing were built upon over generations, and the unwinding of them might take a little longer as well, way after our time is completed over here. But certainly the steps need to happen now. And all we can do is create a sense of urgency and a certain, you know, moral imperative to take action, right? So even if we begin with a simple call to action around acknowledging, collecting, and reporting data with and amongst the Native people. Oftentimes we collect information, but we never complete the loop back, right? So how do we do that much more transparently in a timely manner so that we build the confidence and trust? The time to build the trust is not so close to the desired time. It'll take a long runway and persistent efforts, not just one-time efforts. The second call to action that I would say is for all of us to make sure that we have decision-making that includes tribal voices, right? So it's much more of a participatory design, very inclusive model from the early conception of the project implementation, whatever that might be. Instead of me recommending or prescribing a treatment, how may we just find out what the perceived need is, and how may the people that we all serve design that along with us. That's the second one. And that goes part and parcel with just basic courtesy of respect to the individual's humanity, recognition of the trauma, because by recognizing that, we also have simple, really validated tool sets that is trauma-informed care that you're very much familiar with the background. But there's no reason why how we train healthcare teams in basics of customer experience. How may we also train them in the basic 101 of trauma-informed care? How may we start training them for motivational interviewing in medical school? So it should start early. And I think finally, one call to action is for strategic investment in community-based programming that is led by a steady pipeline of indigenous people who are in the provider role. We just need more people that are from within that community to be in that care provider role to rebuild the trust.
Yeah, recognize them, empower them, involve them, really, isn't it? It's the steps. There's some really practical things there. Just acknowledgement and awareness, get the data, map the data, monitor, knowing where things stand is always the number one key, and give decision-making power. And people, when diversity is around the table, better decisions are made. It's just let's talk about technology. That was a promise of the talk today as well, and you and me love talking about it. What role can digital play? You really hinted that adversity sometimes brings some of the best innovation. So let's talk about where digital is playing a role in reducing this gap of health equity.
Yeah, certainly. I think once we lead with the premise that the digital is on the terms of the users, where they
Mm-hmm.
have full understanding of the scope of what's shared with whom, and having a sense of at least some control over data ownership. I think if we lead with that, we'll perhaps have better engagement with native tribal communities, right? And that's the first, privacy and security of data. But then once you establish that and make it easy, we have seen that the adoption of digital solutions has been fairly good. Um, native communities are also mobile first. Um, they do prefer, of course, the preference is in person, hand to hand, eye to eye, that type of relationship over time. But at the same time, even the elders, many of them are adapting to the digital world and conducting meetings, tribal elders council meeting, all on Zoom. We see that governance is on that type of platform overnight, right? And likewise, we're seeing an adoption for metabolic health, adoption of digital for mental health, certainly increased use of solutions to drive unmet social need connection to care. For example,
Mm-hmm.
non-emergency medical transport, that type of digital health interventions that are not necessarily medical seems to have a lot of potential for the tribal communities, where the non-clinical providers such as home health aid or the shared ride drivers could be from within the community, and how that money can then stay within the tribal community in a circular fashion. So that's an exciting area to look at, the expansion of digital health services beyond acute care into
Mm-hmm.
the mental health integration into primary care, and then social care integration into primary care as well. The second area that we are looking at doing more is on the ag tech. And essentially what I mean by that is looking at ways to connect individuals and families to grow your own health at home. Starting out with a simple starter kit of an herb or one tomato plant. We will provide the kits, we'll provide digital agricultural tech support, and you can take pictures, share it back. And the Mashantucket Pequot Agriculture Department team will assist you and help you scale your home garden. So that's just a small type of digital health intervention that is not necessarily in the traditional way, but hopefully allow the tribal communities to regain control over food sovereignty.
Wow. I want to be part of that. Sounds great. Being able
Lots
to
to look
build your own
forward to.
garden. Absolutely. We're coming to the closing of our live conversation, our Reach Live, our inaugural event. And thank you so much for everyone who's joined. Final comments from you, Setu. I mean, we've covered a lot of ground. I would love to keep talking, as always, but what do you want to leave people with? What would be the final thoughts that you'd like to share?
Hey, listen, if we survive this past 1 year, we can do it. We can do anything. And at least personally, I found out that I don't really need too much, right? I figured out that, as long as we are healthy, the family is healthy, we have someone that we can share stuff with. Um, that's all that really matters at the end of the day. So cherish those connections that we all have, and keep plugging at it one day at a time.
Yeah, absolutely. Where there's a will, there's a way, and you're right. The adversity we face now, and the way people have come together in such a beautiful way as well. And great. Thank you so much, Dr. Vora, for your time.
Thank you. Appreciate it.
Thank you everyone who joined Reach Live's first event. We'll be running Reach Live on every fourth Friday of every month, and there'll be a new incredible speaker each month. So do tune in. But for now, thank you. Have a wonderful Friday, and wherever you are in the world, and enjoy your weekend. So with that, we take your leave, and we thank you so much. Thanks for joining.